faculty and also my peers and see how I can develop as a leader.
So it's actually inspired me to really think deeply about who I am, not just as a leader, but as a person.
Just by connecting me with some really interesting people who have already had some great achievements and who I think will go on to have even greater achievements.
The HLA has empowered me to consider leadership in all its shapes and sizes and to recognise that I am also a leader.
I like to be pushed a little bit out of my comfort zone, so I think when you start to feel uncomfortable with things, that's a good stimulus for growth. If you're not feeling uncomfortable, then I think you start to stagnate, and I think that's what the HLA offers as an opportunity to do.
To think about my own leadership style, and also to try and put on paper some initiatives I'd like to lead in the future.
I can develop as a leader of the team that I'm already involved in with Medics, but also pick up extra skills that will make me more effective in leading medical, clinical teams in the future.
Leadership
is effective.
Strong leadership inspires people to work independently, but it takes real skill in leadership to bring people together for real change.
The biliary tree starts with bile being produced by hepatocytes in the liver. The bile can be stored in the gallbladder, which drains into the cystic ducts, or the liver can directly secrete bile via the left or right hepatic duct, which unite to form the common hepatic duct. The common hepatic duct and the cystic ducts unite to form the common bile ducts. And secretions from the pancreas will drain via the pancreatic duct to meet the common bile duct at the hepatopancreatic ampulla. All these secretions can then flow into the duodenum for their function, more specifically in the second part of the duodenum. These secretions are controlled by the sphincter of Oddi, which is a muscular sphincter surrounding the hepatopancreatic ampulla. So that's a quick presentation on the anatomy of the biliary tree.
Hi, my name is Eamon. I'm final year medicine at University.Academy and also the S.Stocks community manager. Today we'll be going through how to get involved in leadership education, as well as going through how to do the cranial nerve examination. So both these topics are so important, and we'll be starting with cranial nerve examination. I know when I was starting out in first year, this was such a difficult task to do, especially since it comprises so many different parts of examinations, and on some of the nerves require more than one examination, so it's definitely hard to get your head around. But Hannah does such a great job. She basically did cranial nerve examination on her brother, and it was just amazing. So I definitely recommend looking at her particular video, and I definitely think she did an awesome job. So now we'll be moving on to Hannah, and then we'll go on to Sarah and Radhika, who will teach you about leadership education and how you get involved in that. Enjoy, guys.
Hello and welcome to my teach on cranial nerves. My name's Hannah Beer. I'm an intercalating medical student, so I'm going into 5th year of medicine next year. This teach is aimed at people in kind of the early years prior to clinical exposure, really. So I'll be teaching some of the basics to do with cranial nerves and showing you examination of cranial nerves, because I've got my brother here who will be acting as a patient for me. So let's get started. By the way, I'm not a neurologist, but I do have quite a lot of experience. I've had a couple of OSCEs on the cranial nerves already, so I should be able to give you some top tips. Okay, so to start off with, what are the 12 cranial nerves? Well, they're pairs of nerves that run on the underside of the brain, and they control motor and sensory modalities of various parts of the head and the neck. So they come in pairs, and there's 12 of them, so there's a lot to learn. So I'm going to give you a bit of an overview about how you might go about beginning to remember these nerves and what they do, and then how you can relate that to your clinical examination. So how are we going to remember all 12 of these nerves then? So they come a lot of the time with Roman numerals, so it's worth having a little read about your Roman numerals if you aren't quite sure. Don't worry, I didn't know Roman numerals in first year of medical school either. Really simple though, so go and look it up. So they're numbered 1 to 12, and they run through olfactory, optic, oculomotor, trochlear, trigeminal, so on. You can read for yourself. And A clever way of remembering all 12 is via a mnemonic, because it's kind of handy to remember what order they come in, and in an exam setting, such as like a multiple choice or something, you can use the mnemonic to help you remember what number each nerve is before it becomes second nature. The more familiar you get with them, the more you'll be able to remember, oh yes, facial nerve, that's nerve number 7. So the mnemonic that I've used is ooh, 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 to touch and feel very good velvet, ah, heaven. Bit silly, I know, you can probably make your own mnemonic to help you remember it better, but that will just help you to remember the actual names of the nerves and what order they come in. So another thing that's quite useful to remember is what modalities each of these nerves carry. So are they a sensory nerve? Are they a motor nerve? Or do they fulfill both functions? And for this, we of course have another mnemonic. Some say marry money, but my brother says big brains matter more. So where you see an S, that of course means it's a sensory nerve, M, motor, and B means it carries both modalities. So I used to, in our multiple choice exams, which we have in Exeter Medical School, write those down on a bit of paper in multiple choice exams, so I definitely couldn't get things wrong. It just helped me to get things straight in my brain. So it's important to remember what the nerves are called, what number they are, and what modalities they carry. It's a good place to begin. So there's lots of summaries of all of the cranial nerves and exactly what functions each of them fulfill. I'm not going to regurgitate that here for you right now, because you can have a good read for yourself. It's basically just important that you remember a few key features about each nerve at this stage, and you can remember broadly what they do. I don't think it's worth, in the early stages, getting bogged down with exactly what nerve does exactly what portion of innervation of the taste of the tongue, for example. You can get quite bogged down with all of that detail. So just keep it simple for now. And Geeky Medics has a really good overview article with a little PDF table that you can download at the end, which is good for starting out. So I'd recommend that. So let's dive into now some of the actual nerves and what they do. So I'm going to start by talking about some of the nerves that come first. The olfactory nerve is nerve number 1. That does smell. So let's park that. Let's move on to nerve number 2. That does vision. So most of the nerves at the front end of that table of 12 are to do with your eyes, sensing the light, and also moving your eyes around. So I think that's a good place to start. So nerve number 2, cranial nerve number 2, is the optic nerve. Now this is only a sensory nerve. This senses the light coming into the eyes. Then all of the other nerves to do with the eyes are movement nerves. So the oculomotor, trochlear, and abducens nerve all move the eyes. Okay, so sorry, I'm just getting a bit, Zoom is very new territory for me. So first of all, let's get my brother over here to help me. What I'm going to do, guys, is teach you a little bit about what each nerve does and then show you how it's examined, and we'll go through like that, if that works. So cranial nerve number 2, the optic nerve, is to do with how we see things. And so our vision can be divided into visual fields. You guys might be familiar with this diagram. This shows how the optic nerve runs through the brain to send the messages to the brain about the light that it receives. So it's important that when we're assessing our vision of the patient, we can determine whether they can see and what they can see at what distance. That's their visual acuity. That's the Snellen chart with the numbers. But it's also important that we assess their visual fields. So whether there's any parts of their visual field where they can't see, because that might give you a clue as to whether there's any lesion anywhere along the optic tract. So where the optic nerve runs into the brain to relay that sensory information. Visual inattention is another thing that you can assess, which is to do with what a patient can and can't see and what they are paying attention to in their visual fields, but that's not routinely done as part of a cranial nerve examination. So we are going to assess vision and visual acuity. That comes first. I'll do all the eyes in a minute. I've got George waiting here. Let me just run through a couple of other things first. So another thing that we need to assess when it comes to vision is the pupils and what the pupils are doing. There's two nerves which control the pupils. There's the optic nerve, which is only a sensory nerve. So that carries the light information to tell the pupils what to do. And then there's the oculomotor nerve, which carries the motor information to the pupil to tell it what to do, whether to constrict or dilate. And these are under both sympathetic and parasympathetic control. So pupil dilatation is a sympathetic motion and pupil constriction is a parasympathetic motion. So just remember that, that can come in quite handy for exams. Pinpoint pupils, opioid overdose, parasympathetic. Okay, so then we're going to talk about eye movements. I'll show you all of this and bring it all together in the examination in a second. Sorry, George, you will get to do something in a minute. So just to go over eye movements then. So these are under control of 3 different cranial nerves. So we've done the light detection, visual fields, we're now onto eye movements. So there's various muscles that move the eye and they're each innervated by something different. So I've color-coded them here on my slides so you can see them easily. So you've got these 4 muscles here, the rectus muscles, which are these straight muscles on either side of the eye. And they control moving the eye up, down, or from side to side in vertical planes of orientation. And then you've also got these oblique muscles, which are to do with intorsion and extorsion of the eye. Now, this all might seem quite complicated to remember because they're all innervated by different things, but I've got a handy way of remembering them. So I remember them with the chemical formula expression LR6SO4. Now what that means is the lateral rectus muscle is innervated by cranial nerve 6, which is the abducens nerve. And SO4, the superior oblique muscle, is innervated by cranial nerve 4, or the trochlear nerve, which also conveniently means pulley. So, because you can see there's a little pulley there on that superior oblique muscle. And then everything else is innervated by the ocular motor nerve. So the superior rectus, medial rectus, inferior rectus, and inferior oblique are all under ocular motor control, cranial nerve 3. So that's eye movements. And if you'd like a bit of a better explanation about exactly how those muscles move the eye and where, I refer you to this really good YouTube video here, which summarizes it better than I can. I'm going to focus now on what we actually need to do to examine those nerves to do with the eye to see if they're working properly. So cranial nerve examination can seem a bit daunting. So I have a way that I structure it to make sure that I can remember it, because actually it's a relatively easy examination to do. So I think about the body parts that I'm examining rather than getting bogged down with the nerves when I'm actually sat in front of my patient. So I think of it in terms of systems. So I think first and foremost, smell and eyes, then face sensation and movement. Then I think hearing and balance, tongue and swallowing, and then finally I'm on the home straight doing my head and neck movement. This just groups the nerves together in a way that's a little bit easier for me to examine rather than just going 1 through 12. And I find it just helps me to remember it better and it makes it flow a bit better. So when might we be doing a cranial nerve examination? Well, it's indicated if a patient comes in with headaches, any visual changes or stroke-like symptoms such as facial drooping, unilateral weakness or paralysis, any problems with their speech or swallowing, or any hearing or balance changes. So there's various scenarios where we might want to pull out this examination. So let's begin examining. So first of all, you'll go into your OSCE station and you must make sure you read the OSCE brief, because sometimes they might only ask you to examine nerves 1 to 6 or whatever. So you must make sure you're doing the right nerves rather than just running through the whole examination if it's not asking you for that. So we're going to start off with an introduction. Let me go and sit here. Can I reach the mouse from here? I can. So I'm going to explain what the procedure involves and gain consent. So, hello, George. I'm not meant to know your name, you're just a patient. Hello there, my name's Hannah Beer. I'm a 4th year medical student at the University of Exeter, and I've been asked by the doctor today to come and examine your cranial nerves, which are the nerves that provide innervation to your face, your neck, your hearing, your balance. Basically, I'll be examining your face today and asking you to do a few things. Does that sound like it would be okay with you?
That's fine.
Could I just confirm your name and date of birth, please?
George Beer, 20th of November 2000.
Lovely, thank you. Is it all right if I call you George?
It's fine.
Great. So at this point, I'd of course wash my hands and get my bits and bobs ready. So for the purposes of this examination, I've got a few things. Obviously, when you're in an OSCE station, look at what they've given you. What they've given you will give you a clue as to what you should be using. So here I've got a pen torch. I've got a neuro tip. Well, I've got a pencil for now. I've got a bit of cotton wool and I've got a tuning fork. So we'll be using all of those today. I've also got a tendon hammer somewhere on the floor. Okay, so I've got everything that I need ready for my examination. I will wipe it down to make sure it's all clean before I use it on the patient. I've confirmed the patient's identification, gathered my equipment. Now, the first really important thing that you need to do for cranial nerves is make sure that your chairs are positioned correctly. I have been a mock patient on somebody who's failed a cranial nerve examination before for examining a patient supine on the bed. Don't do that. You want to be facing the patient. You want to be roughly the same height. Unfortunately, my brother's a little bit taller than me, so he's not quite at my eye line, but ideally your eyes should be meeting. Your knees are just about touching. You're about 1 meter away from the patient. Don't worry, this is my brother. Social distancing doesn't apply here. Okay, so that's a really important thing. You want to be orientated in the right way. So let's begin my examination. So first of all, I'm going to ask him some questions. Have you noticed any changes to your sense of smell recently?
No.
No. Asking that question is enough to assess the olfactory nerve, cranial nerve 1. It's not, we don't routinely ask patients to smell anything. I presume often we don't have things to smell on hand. Now we'll move on to eyes. Have you noticed any changes to your vision lately? Any double vision or blurring of your vision? Okay. Do you normally wear glasses?
No.
No. Okay. My brother doesn't wear glasses. If your patient did wear glasses, you'd ask them to put their glasses on, but have a good look at their eyes before they put their glasses on, because they'll need them to be able to see you properly and for the examination to go on properly. So, first of all, I'm going to have a good look at my brother's eyes. So I'm looking for any asymmetry. Am I seeing any drooping of the eyelids? Is the pupil size symmetrical? Any gross abnormalities there? Then I'm going to move on to visual acuity. So cranial nerve 2, the optic nerve. Normally there's not a Snellen chart provided to you in an OSCE setting. So I found that a good substitute and a substitute for on the wards is getting someone to read your name badge. They kind of should be able to read your name badge from about 1 meter away. I'm not wearing mine right now, but George, could you please just read what it says to me on my name badge?
Hannah Beer.
And then I'd get him to cover the other eye. So you should have been covering one eye.
Oh, okay.
So can you read what it says here?
Hannah Beer.
And then I'd turn it over and get them to read something else. So that's fine. If they can't read your name badge, that's when you then progress onto something such as count fingers, visual acuity. So how many fingers am I holding up?
Fine.
The thing is, we know that George has quite good vision. Finger count vision is actually very crude. If you're at that point, you've clearly already lost a lot of your vision. So it's not really a reliable enough initial test for somebody who's got presumed healthy visual acuity. So you do that one eye at a time. Now we're going to move on to looking at the pupils. So for that, I've got my pen torch. I'm just going to stop. Should I stop sharing the screen? That's fine. Okay, so George, I'm just going to be shining a light in your eye now. It might be a little bit uncomfortable. Please tell me to stop if so. Patient comfort is important throughout. Doesn't matter if you do the examination a little bit wrong, you must keep your patient comfortable and safe. So we're going to be looking at direct and consensual pupil responses. So what that means is I'm going to be shining a light into the left eye to start off with, and looking at the left eye to see that pupil constricting. What should also happen if I shine the light in the left eye is the right pupil should also constrict at the same time. That's called the consensual response. So what I would do is pop my hand in the middle of his face. You can just move over a bit, just this way so you can see a bit better.
Yeah, angle it up.
Yeah. So I'm going to be shining the light into your eye now. I'm popping a hand down the bridge of his nose so the light doesn't bleed from one eye to the other. I'm shining the light in the left eye. I'm looking for pupil constriction. I'm then shining the light in the left eye. I'm looking at the right eye, and the right pupil constricts normally. I then repeat that on the other eye. We can then also do the swinging light test to assess the pupil constriction. And what that tests for is a relative afferent pupillary defect. So obviously for pupils to constrict properly, they must first sense the light and then using the optic nerve, and then send a motor response through the ocular motor nerve to tell the pupil to do the constriction. So if you have a problem with the optic nerve, I might shine the light in the left eye, swing it to the right, and the pupil would dilate if I had a relative afferent pupillary defect. So the pupil would dilate in the affected eye, and that would be a sign of an abnormality, which of course is not present in my healthy patient. Cool, so we've done pupil responses. The last thing we should do there is then accommodation. So that's looking at what happens to the pupil when you focus on something close by and far away. In a healthy person, when they look at something close up, their pupils should converge, so come together and get a little bit smaller, so constrict. So George, I'd ask you to just look at that light switch behind me on the wall. And then when I tell you so, just to focus on my finger, which I'm holding about 30 centimeters away from his face. So look at the light switch and look at my finger. And I was just observing for the pupils converging and constricting. That was all fine. Okay, perfect. So we've done that. Now we're going to go on to visual fields. So to do this, you want to be sitting directly in front of your patient, and you're effectively comparing your visual field with their visual field. So George, could you just cover one eye for me, please? And you want to be covering the mirror image on yourself. And then using your hand about ½ meter in front of you, and you want to be keeping it in that same ½ meter plane the whole time. George, I'd like you to tell me when you see my finger come into your visual field and when you see it coming in, okay?
Yeah. Yeah. Yeah.
Now I'm going to change hands.
Yeah. Yeah.
Okay, they must keep their head still and look directly at you at all times. And then you'd repeat that on the other eye. It's worth practicing that one, as it's really easy to let your arm drift forwards and backwards, which makes the test a little bit less reliable. And you want to make sure that you assess all 4 quadrants of vision on both eyes. And yeah, this trick of you swapping your arm over so you can use the other eye is use the other arm, sorry, is a really handy one to remember. Thank you very much. Cool, so that's visual fields. I use my finger to test that, but if provided in your OSCE, you could use the pin with the white end to do the visual field assessment. If in your OSCE as well, you've also been provided with a pin with a red end, that's telling you to assess the blind spot. And similar to visual fields, you'll be comparing your vision with their vision. So you'd get them to cover one eye, and moving in from both sides with the red pin very slowly. You'd ask them when they see the red pin and to tell you when it disappears for them, and that shows their blind spot. If they've got a large blind spot, that could be pathological. So again, you're just using your vision to compare to them. So that's assuming your vision is normal as an examiner. Okay, so we've done those special tests for the eyes, and the one that I like to leave till the end to make sure that I've done everything else before I do this one. I like to keep this one to the end, so it's like a marker of, right, I'm finished with the eyes now. I do eye movements last. So in order to do that, you ask your patient to sit still. And again, looking at your fingers They need to keep their head still and follow your fingers as you trace them in an H shape. Observing for smooth eye movements and looking to see whether they have any nystagmus, which is where the eyes kind of shake around a bit. And you also want them to tell you if they experience any double vision throughout doing that test of mapping out the H in front of them, because that could tell you that there is a problem with one of the nerves that controls eye movement, so cranial nerves 3, 4, or 6. So those are all the eye examinations that I would recommend. So we've done all of those ones there. So what do we move on to next? Well, next I like to examine the face. So I think of doing the trigeminal first, because that's cranial nerve number 5. So the trigeminal nerve is the nerve that is concerned with innervation of the skin of the face and also the cornea. So it's divided into 3 key areas: the ophthalmic, maxillary, and mandibular branches. So when we're testing the sensation of those, we need to make sure that we test all 3 on both sides of the face. So normally you'd use a neurotip for this, which I don't have, so I'm going to be using a pencil. Principle is the same. So George, I'm going to be assessing the sensation of your face now. I'm going to be touching you with this little sharp neurotip. Shouldn't hurt, but please tell me to stop if it is hurting you. So this is what it feels like. So you want to try the neurotip on a central area, normally just above, between the 2 clavicles here. This is what it feels like. Can you feel that okay? Yeah. So what I'd like you to do is close your eyes and just let me know when you can feel this touching your skin by just saying yes.
Yes. Yes. Yes. Yes. Yes. Yes.
Brilliant. So he had his eyes closed throughout. Now, George, I'm going to repeat this with some cotton wool. So you just take a bit of cotton wool, do the same thing, tell them what it feels like on a central point, and then we repeat for all branches. It's okay. I don't think we have to show them that as well. So you do it with cotton wool too. Then while you've got your cotton wool out, it's a good reminder to say to your examiner, I would normally assess corneal reflex as well, which is done by putting a tiny bit of cotton wool onto the cornea and observing for your patient blinking reflexively. But of course, that's a bit uncomfortable, so it's not routinely done. So you'd say, I'd normally assess the corneal reflexes. If your examiner wants you to do that, they'll say, oh, go on then, do it. Normally they'll say, yes, yes, that's fine, and you don't do it. Next, the other thing that the trigeminal nerve does is provide motor innervation to the muscles of mastication or chewing. So, George, I'd like you to clench your jaw for me, please, and unclench it. And I'm just going to feel the area of your forehead and your jaw while you do that. So I'm feeling up here. If you clench, unclench, you should feel the temporalis muscle contracting. And then you also feel at the angle of the mandible, and you should feel the masseter muscle contracting. George, could you open your jaw for me, please? And I'm just observing that it's open nice and symmetrically. And now just don't let me close it. Just pushing it with my hand. And just swing your jaw to one side and resist me here. And swing your jaw to the other side and resist me here. There we go. We've assessed power of the mastication muscles as well. For completeness now, we will assess the jaw reflex, which is another job of the trigeminal nerve. So we do that by just placing a finger on the chin. I'd just like you to look towards me, George, and just relax your mouth. And you just, onto your finger, which is just underneath the lips, gently tap your tendon hammer, and you should see the jaw reflex nicely there. A very brisk reflex would be pathological. A brisk closure of the mouth would be pathological. Okay, so we've done face sensation and muscles of the jaw. Now is a good time to do the motor parts of the face. So this is the facial nerve's job. Pardon me, it's very easy to mistake the facial nerve for controlling sensation. That's the job of the trigeminal nerve. So first of all, I'm going to have a good look at George's face. I can't see any obvious drooping or asymmetry, which might be a sign of facial nerve abnormality, such as Bell's palsy. The facial nerve also does an element of taste. So have you noticed any changes to your sense of taste, George?
No.
No, that's normally enough. And now we're going to assess the movements of the face. So there's the facial 4 movements, which I'm going to show you up close. So you ask the patient to raise their eyebrows like this, surprised, to purse their lips, to blow out their cheeks like a puffer fish, and also to do a big smile. So George, could you raise your eyebrows for me? And just purse your lips. Big cheesy grin, and puff out your cheeks. We're then going to oppose some of those motions. So George, could you raise your eyebrows for me, please? And I'm just going to try and push them down. Okay, puff out your cheeks, please, and don't let me push them in. That's great. And we can do the pursed lips as well. Purse your lips for me, please, and don't let me pull them apart. That's great. So that's the facial nerve done that's in charge of all the movements of the face. So this is our checklist. This is what we've done so far. So now is the right time to move on to hearing and balance. Now, technically, any hyperacusis, so loud noises, that is actually the job of the facial nerve, because the facial nerve innervates the stapedius muscle, which controls how loud we hear things. But I just ask this here and now because it just makes sense to think body systems for me at this point. So George, have you had any trouble hearing lately?
No.
Have you had any trouble with hearing sounds too loudly?
No.
No. Brilliant. So we're now going to assess the hearing, and we'll do each ear one at a time, covering the other ear. So what I do is do you want to move just to face the camera now? So I'm just going to cover one of your ears. I'm going to whisper a number, and I need you to tell me what it is. So I'm slightly rubbing the tragus on his other ear, not too vigorously. That'll just muffle the sound in the ear that I'm not testing. So I'm going to whisper a number. Can you tell me what the number was?
No.
Oh, right. It's clearly been blasting loud music. Let's try again.
44.
Oh, you got it this time. And we'll do the other ear.
65.
Okay, might do another number, but we don't want to embarrass you, do we? Okay, then we move on to doing Rinne's and Weber's tests with a tuning fork. Rinne's and Weber's tests are important in determining whether you have conductive or sensorineural hearing loss. So don't worry too much in a cranial nerve exam. They often won't ask you to distinguish between the two tests. So just think about putting the tuning fork in the right place for now. So I've got a fork here to demonstrate. One thing that examiners definitely hate is if you bash the tuning fork against the metal chair leg. It's far too loud. You really don't need it that loud. So the best way to make your tuning fork make a noise is just to lightly pinch it, and then it will start vibrating. So George, imagine this is vibrating, okay? So first of all, I'm going to start by doing Rinne's test. And I remember the way around it goes. Rinne's is right by the ear. That's how you remember it. So George, what I'm going to do is I'm going to place this tuning fork just on the bone behind your ear. I'd like you to tell me that you can hear it. I'd like you to tell me when you stop hearing the sound. And then I'm going to bring it in front of your ear, and you can tell me whether you hear it there. Okay?
Okay.
So vibrate my tuning fork right on the ear. So can you hear that?
Yeah.
Tell me when it goes away. It's gone away?
Stop. Yeah.
Then you bring it towards the front of the ear, and it should be louder in front of the ear than it was on the bony prominence. Was it louder in front of the ear?
Indeed.
Indeed it was. So there we go. That's good. That shows there's no abnormality, because air conduction should be superior to bone in somebody who has no conductive hearing loss defect. We then do the Weber's test, which is where, well, I'd repeat that on the other ear. Then we do the Weber's test, which is where we vibrate our tuning fork again, and we put it right in the middle of the forehead there. And George, do you hear it louder in either ear?
No.
No, you shouldn't be able to hear it louder in either ear. If you do hear it louder in either ear, it may be a sign of conductive hearing loss, where something like a big plug of wax is acting like a resonance chamber and causing the conduction of the sound. So here's just a summary of Rinne's and Weber's tests for you. You can find that explained in many places online. I won't bog you down with it here. Basically, for the purposes of the cranial nerve examination, remember to place the tuning fork correctly in the bony prominence behind the ear, and then remember to ask them when it stops, when they stop being able to hear it, and then you bring it in front of their ear, which should be louder for them. Okay, so we've done hearing, but I missed out balance. This is real life medicine, folks. It's because I'm trying to perform at the same time. So that was the hearing part of the vestibular-cochlear nerve, cranial nerve 8. Now we need to assess your balance, George. So could you get up off your chair, please? And what you need to do is you need to ask the patient to walk on the spot with their eyes closed, but you need to be ready to catch them if they fall. So George, could you close your eyes, please? And just walk on the spot for me. And you'd be looking for any drift. George is absolutely fine there. That's great. Take a seat for me, please. So we'd sit back down. And there's a reason you do the cranial nerve examination in a specific order, to avoid the patient having to get up and down all the time. Okay, so that's the vestibular-cochlear nerve done. We've done hearing and balance. We're now going to move on to the later cranial nerves, so tongue and swallowing, which are basically glossopharyngeal, vagus, and hypoglossal nerves. So I don't actually have a tongue depressor on me, so I'm not going to touch your tongue today. But basically, the first thing you need to do to assess the glossopharyngeal nerve and the vagus is to have a good look at the soft palate. So the area at the back of the mouth where you see the dangly bit coming down, that's your uvula. When you say "ah," you should see the soft palate move up like a roof coming off a house. And that is normal, and it should be symmetrical on both sides. So George, I'm just going to shine the light into your mouth, please. Could you just stick your tongue out and say "ah"? Nice contraction there, and his uvula is nice and central, so that's all normal. Have you had any problems with your swallowing recently?
No.
Okay. Could you just swallow for me, please? And could you just cough for me, please? Seems a bit weird coughing on me in a COVID world. Okay, that's normal. He's got a nice cough there. You'd also turn to your examiner and say, I would assess the gag reflex, but obviously that's not routinely done. That would be done with a tongue depressor or something just towards the soft palate. So that's fine, we've got that done. Also, George has been speaking to me today. I've not observed any hoarse voice, so I don't think he's got any vagal nerve pathology. I don't think he's got a problem with his recurrent laryngeal nerve branch of his vagus nerve. No hoarseness there. Good. Okay, so now I'm just gonna, to finish that bit off, have a good look at the tongue just to check for any asymmetry, any deviation, or any fasciculations of the tongue. Okay, so the tongue is nice and symmetrical, there's no fasciculations, it's not deviating to one side or the other, which would be a sign of a hypoglossal nerve lesion. Now I'm going to just test the motor capabilities of the tongue. So George, I'd just like you to stick your tongue into one of your cheeks, please, and just don't let me push your tongue away. And just the other side. Like that. So if you guys couldn't see that properly, George was just putting his tongue in his cheek like this and resisting me pushing it. That's fine. So that assesses tongue power, which is the hypoglossal nerve. Okay. So these are the nerves that we've done so far. So we've got one left, the accessory nerve, which is, I think, my personal favourite cranial nerve, to be quite honest, because when I learnt about it, somebody used some GIFs of Beyonce to help me remember, because she is the queen of the shoulder shrug and the hair flick, which are the chops of the traps, the trapezius muscles at the back, and the sternocleidomastoid muscle, so that muscle which is strap-like that goes along your neck here. So to assess this, we need to see whether George can shrug his shoulders. So George, could you just shrug your shoulders up and down for me, please? He has recently dislocated his shoulder, so might cause him some pain. That's great. And could you just turn your head from side to side, please? That's brilliant. And now we're going to resist those movements just to check that power is intact. So could you shrug your shoulders up, please, for me, George, and just don't let me push them down. That's great. And turn your head to one side for me, please. And don't let me resist me. Didn't phrase that very well. And turn your head to the other side, please, and just resist me. That's great. Thank you very much. Okay. That concludes the examination.
Thank you very much.
I'll just, at this stage, wash my hands and thank my patient. So we've done all of the cranial nerves. So of course, I'm going to thank my patient, say that concludes the examination, wash my hands again, and present my findings to my examiner if that's appropriate. So that concludes my teach, guys. Thank you very much for watching. I've tried to make it quite quick, so if I've whizzed through anything and got you confused, please feel free to ask me a question. Thank you very much, George, for being my patient. Okay. And my top OSCE tips that I would give to you guys are just practice, practice, practice on anyone that will let you practice on them. It's really good to practice with somebody who maybe isn't doing medicine, because it makes you realise that some of the instructions that you might be giving aren't necessarily that easy to follow. As in, George, sometimes I wasn't very clear, right? I'm a little bit rusty. It's been a while since I've done an OSCE, as I've been intercalating for the last year. But just make sure that the instructions that you're giving to your patient are clear and they know exactly what you're asking them to do. Also, make sure you warn and explain them before you do anything, explain to them before you do anything what things might entail, because you'll obviously be coming at them with relatively sharp things in the cranial nerve examination, such as the neurotip. Also, always remember to dispose of your waste appropriately in an examination. So if you have a neurotip, make sure you pop it in the sharps bin. And I cannot stress this enough, make sure you're sitting in the correct position, because you will definitely fail the station if you're not sat appropriately with your patient, particularly for the eye examinations. So thank you very much, guys. I hope it was helpful.
Thank you.
Take care.
Thank you so much, Hannah. That was great. I think that was really useful, and I mean, I feel like anyone that watched it can learn a lot about cranial nerve examination by doing that, and I think we all should have a good idea of cranial nerves. I mean, cranial nerve palsy just happens so much in hospital, regardless of like what specialty you're in. It could be ED, ophthalmology, ENT. So I definitely recommend like learning that as much as possible, watching Hannah's video, and like just getting to make sure that you know everything. So thanks, Hannah. And now we'll be going on to Sarah and Radhika, who will teach you about how to get into leadership and education. Leadership and education are so important for any CV, and it's basically what you need to apply to quite a few different specialties, especially the more competitive ones. So I definitely recommend watching this video, learning what to do, and getting involved as early as possible, especially if you want to get into like something like surgery or something like that. Yeah, so take it away, Sarah and Radhika, and enjoy, guys.
Hello, my name is Radhika and I'm a final year medical student from Queen's University Belfast.
And I'm Sarah Saram and I'm a final year medical student from the University of Birmingham. We're both really excited to be able to welcome you to our Master in Medicine conference, and we hope that you'll find this talk really enjoyable as well as useful. This talk is basically it's meant to try and open your eyes up to the many opportunities that are available to you in medical school, and how this can find a strong CV for any portfolio.
So just a disclaimer before we start, this is just our perspective as final year medical students, and in no way do you need to do all the different things that we suggest and take on any advice that we do give in this talk. We haven't done everything ourselves. We just wanted to give this talk just to give a bit of advice kind of to our younger selves, and to give some younger year students just a bit of insight into what they can do over medical school, just to make their portfolio and their CV more competitive in the future. So with that, I'm going to start to talk about why it might be a good idea for you to talk about your portfolio now and the different portfolio requirements. So why do I need to think about my portfolio now? So in medical school, it's often a misconception that medical school is actually too early to start thinking about your portfolio and applying to specialty training, and that you should just wait until you're a foundation year doctor. And while you can 100% do this, starting to get involved in things in medical school gives you a bit more time to bulk up your application, and also lets you explore your interests and decide what speciality you ultimately want to end up applying for. As well as this, there are also lots of opportunities that are only available for medical students. So for example, some bursaries to go to conferences or some essay prizes. Lastly, doing these things can often make you a more balanced doctor by the time that you graduate, and can actually make medical school more enjoyable. So with that, I'm going to talk about the different requirements for different portfolios. So starting with putting together a portfolio, you can either keep your things either in online format, so the NHS has an e-portfolio website that you can track everything, or you can keep a hard copy. And for specialties such as surgery and paediatrics, you actually need a hard copy because you bring that copy to the interview. Different specialities in different regions will often have different requirements, so it's always best to check with the specific job that you're training for. But as this table shows, most portfolios kind of cover three main areas, which is research, medical education, and leadership. And that's what we're going to focus on in this talk. So starting with research, for some medical school students, this really excites them, and for others, it fills them with dread. And as with all things, either response is okay, and you shouldn't force yourself to like something that you don't like. But in medical school, it's often a misconception that all research in medicine is lab-based, but in fact, medical research can be very varied. So it can involve statistics, and this is the case in a lot of public health research. It can include lab work, like I've said already, so like research in cancer genes, or it can also be qualitative, so doing things like focus groups. As well as this, audits and quality improvement projects are also very valid examples of research. And if you do these well, there's no reason why you can't present this at top conferences or even get your work published. One really important thing when you're looking for research opportunities is to pick your opportunities wisely. In medical school, we're so busy, and often we don't have time to fit in these other things on top of our clinical work and revision and going to placement. So one really good thing to do is just be honest with your supervisors about how much time you can commit, and look for opportunities kind of in the breaks of medical school. So for example, lots of universities offer summer studentships, and these are often quite competitive, so don't be disheartened if you don't get one. You can just approach your doctor just to do some work over the summer. And with that, I'm going to pass over to Sarah, and she's going to talk about medical education.
Thanks, Radhika, for your insight into research and portfolios. I'm now going to move on to talking a little bit more about medical education. So what does getting involved in medical education actually mean? Essentially, it's about having a greater say and control over how and what education is taught to medical healthcare professionals, as well as being involved in this process. Why is it a good thing to be involved in medical education as a student? Firstly, is that you're a lifelong learner. This is something that's stressed to you at every stage of your medical school career and beyond. The medical field is a career where you're constantly learning and having to review new information as well as reflect on it, and hence the way that it's taught to you is of paramount importance. This is also likely why there's a major emphasis on the teaching section in almost all the portfolios, regardless of specialty. Number two is the fact that it's an opportune time to get involved with medical education. Now more than ever, we have to be creative in the way that we're delivering medical education, especially with the restrictions, and it's forcing us to think and reevaluate our old ways of teaching and try to reinvent new ones. Getting involved in medical education is a massive market, and if you're getting involved in making products as well as resources, you might even have the chance to be able to explore the more entrepreneurial side of med ed, which I think is a really fantastic opportunity that can be applied both in and out of medicine. And number three is that you have the chance to explore alternative careers if you get involved in medical education. It opens many doors to careers outside of clinical medicine, and after your foundation years, you might even be thinking about roles such as becoming an anatomy demonstrator or perhaps even a clinical teaching fellow. And further down the line, you might even consider working with trusts, for example, as a head of academy, or working with a university as a clinical lecturer or perhaps an honorary professor. Personally, I built my love for teaching throughout medical school, and it was a real process, and one where I really had to put myself out there. I started off with becoming a BLS instructor, and then I was involved in more schemes as well as charities that allowed me to take on more and more teaching roles. My main takeaway from medical education is that in all my experiences, I've basically found that it was very, very hugely gratifying, and it also forces you to step out of your comfort zone, as well as gain really valuable skills in presenting. But the next slide is me talking about the formal ways in which you can get involved with medical education. And I wanted to show you guys this because they're available to you both in medical school and after medical school. And bear in mind that these all count for points on your portfolio under the teaching section, under teaching qualifications, as well as extra degrees. So starting off with the intercalated years as a medical student. This is usually a year out of the medical curriculum, and the earliest you can take it on is after year 2 in medical school, and you'll find that some universities can offer MSCs in medical education. And one of these is Brighton and Sussex, which offers an intercalated MSc in medical education. I would highly recommend looking at the website www.intercalate.co.uk, which has loads of information all the intercalated degrees offered by all the universities. A big pro about doing an intercalated degree is the fact that you have essentially 1 year of protected time for you to be fully involved in the theory of med ed, as well as pursuing projects and research in this area. The next step along this formal pathways is the academic foundation program. Granted, it's one of the more competitive foundation programs to get involved with, but what it does allow is, again, one rotation, which is about 4 months during your F1 and F2 years, away from your clinical responsibilities, where you can experience one of the following areas, which is clinical research, medical education, or leadership. And finally, the last formal pathway to think about is as a postgraduate, where you can possibly enter into a 3-year master's program in medical education. It's a 3-year course where you get a certification in each of the different years. And the first one is your PG Cert, and then the second one is PG Dip, and then the third one is the Masters in Med Ed. And what this allows you to do is work with universities once you have this qualification. So now I'm going to move on to talking about the opportunities available to you at university and how you can get involved in medical education as a student. And I've tried to keep these pretty general, as I know that not all medical schools will have the same opportunities. So this slide is just to kind of get you thinking, as well as being aware of the opportunities that might be available to you. The first one is getting involved in teaching and mentoring schemes. These are a great way for you to get started in teaching at university, and they do count for portfolio points, depending on how long the course is, obviously. They usually get held by societies, for example, teaching a module or an examination in a year group, and you can often get certificates as well as feedback from the people who are receiving your teaching session, which is a major plus because you do need to have evidence on your portfolio to basically show that you have done this. If you're in your clinical years, I would look into whether there's already an established buddy program or teaching program at your hospital, as you can kind of kill 2 birds with 1 stone at placement whilst you're teaching the younger years over a period of time, and try and gain feedback as so that you have evidence for your portfolio. My top tip in this section is when you do a teaching session where it's over a period of time, it's much better than doing a one-off session. So specifically in the IMT, so the internal medical training portfolio, you score more points if you're teaching over 3 months than if it's only a few times less than 3 months. And this is just something to bear in mind. My second area to think about getting involved in is making learning resources. So more and more societies are essentially getting involved with making webinars as well as virtual conferences and other types of resources. These are likely to be the future of medical education, so getting involved in them will be really hugely beneficial towards you. The pros of this is that you kind of have more control over what's being delivered, and if it's a virtual resource, it's a great opportunity for you to reach a wider audience, as well as a great chance for you to gain greater amounts of feedback as well on your products. So does it count for points? It can do. I'm going to use the example of the internal medical training portfolio again, where designing a teaching course and delivering it over a course of 3 months counts for 6 points under the teaching section, but just making the learning resource alone actually doesn't count as a point. The caveat to this is that certain portfolios, for example, the ophthalmology portfolio, does count making an e-learning resource as a point. Personally, I would like to mention that it may not, whilst doing these things may not all directly lead to points immediately, they're a great opportunity for CV boosting and allowing you to get further roles. A personal example for me was when I joined a startup team, and it was related to creating a med ed product. And whilst the experience in itself didn't lead to many points, basically didn't lead to any portfolio points, it did boost my CV when I applied for more competitive roles in teaching as well as other types of programs. So just something to keep in mind. Whilst it may not count for points now, it might help you in the future. So top tips in this area are to work as a group, because it's often really time consuming and it helps to have other people to divide the work up. Finally, I would like to talk about capitalizing on teaching roles as a student. So this is just keeping your eyes open for any opportunities where you can kind of take on that teaching role and gain some experience. And it may not necessarily be teaching about medicine or teaching medical students. And in the way of portfolio points, some teaching roles do count. So again, on the IMT portfolio point, if you design the course and you teach it over a course of 3 months, it adds up to lots of points. My top tip in this area is essentially if you're applying for any teaching role, the two main things that I always used to do was talk about my passion for the subject, which was demonstrated by X, Y, and Z on my CV, as well as my love for teaching, which was demonstrated by all my teaching experiences that I did in the past. And this just proves that not all opportunities will relate to points, but what they will do is put you in really good stead to applying for those more competitive roles. So with that, I'm going to move on to my next slide, which is talking about leadership. Wonderful. So I'm just going to briefly talk about leadership in the context of portfolios, as my colleague Trisha has a really wonderful talk that you should definitely attend about this, looking at the intricacies of leadership. So leadership is a really difficult thing to try and quantify, especially as a student, and you're always wondering what roles count and what roles don't. But if I had to kind of distill it down into three main aspects of leadership that I'm sure everybody listening to this will have some experience in, it would be leading a group of any sort, representing either a body, a cause, an organization, or a college, and also some sort of organization skills. If you were like me back in my earlier years in medical school, I used to panic a lot about not having those presidency roles, not having those big ambassador roles. But what I would urge you guys to think about is try and think about all the roles that you've had in the past, and have you demonstrated any skills that essentially fall into these three areas? Granted, those experiences may not count as portfolio points, but what you did demonstrate are leadership qualities, and these go a long way when you're going to write them down in your CV and essentially apply for those more competitive roles in the future, and will help you in securing those roles. Now I'm going to talk about the fact that leadership is actually a process, and it's a gradual process. Often as medics, we really want things to happen instantly, and with leadership, there's actually an element of being able to prove that you are up to the task and to build up that strong enough CV so that you can show that you're fit for roles with more responsibility. So I'm just going to use an example here on how building up leadership roles as a student is really important. So starting out, for example, if you have a role within a society that may not necessarily be presidency, it's a fantastic way for you to gain marketable skills, such as working effectively in a team with like-minded people who are also passionate about the same cause, as well as getting a chance to organize events and gain experience in this. However, it does not necessarily count as points under the leadership section of any of the portfolios, but what it can count under is interest for the specialty if you join a related society. The second thing is that society roles can then lead you on to applying for ambassador roles and being successful in securing an ambassador role. For example, if you're an ambassador for a college, so a lot of the Royal Colleges recruit ambassadors from universities to basically be able to act as kind of a liaison student between the college and the university, and communicate about events as well as represent the college. These often require you to be in contact with the college, as well as get invited to events that are held by the college, which are key events which will essentially help you to network and build connections earlier, which can help you out and be a lot more useful than you might think. A personal example is the current project that I'm actually working on with a friend of mine, which is a systematic review. The reason we got into contact with a supervisor for this is because she was organizing an event through a society and contacted him as a speaker, and then established that connection and later contacted him about the project. And this basically goes to show how useful networking can be in securing projects, as well as getting people to help you out later on in your careers. Again, this doesn't count as portfolio points under your leadership section, but what it can count under is interest for the specialty. Finally, ambassador roles might then lead on to regional or national roles, and they have all the former perks that I've talked about, plus additional responsibility, usually in the organization or the project that you're doing, and you have more jurisdiction over the way things are run. And if the role is within a region and it's a managerial role or a trainee representative, for example, then it will count in the way of points on some of the portfolios. But do bear in mind, certain portfolios have very specific requirements, so it's just something that you need to think about. And I would highly recommend looking at the portfolio that you're interested in. So that wraps things up for the leadership section, and I hope this talk hasn't caused too much stress or anxiety to anyone. And it's really just to kind of make you aware of what's out there and have some helpful advice and guidance if you're in your earlier years of medical school and don't really know what's going on. So in conclusion, I'd like to think about 5 top tips that myself and Radhika would hope to impart on you after watching our talk. The first one is that starting early and documenting is a really big and important thing. I hope this, what you've gained talk is that it's that building a portfolio and building a CV is a marathon and not a sprint. And it's something that usually requires quite a bit of time, and starting early is not a bad thing. Keep a record of everything that you do, as well as all the certificates that you receive. I would highly recommend printing out the portfolios that you're interested in, highlighting the areas that you have done, as well as the gaps in what you've done, and targeting those areas. And it can often help to be able to plan out the kinds of opportunities that you want to take as a student for the rest of the medical career that you have in med school, as well as outside of medical school. My second tip would be doing a lot of things doesn't necessarily equate to being very successful or a lot of achievement. And there's a huge amount of opportunities at medical school, but they're not all necessarily worthwhile. So it's easy to get sidetracked by many, many things that other people are doing, but take a moment to think about what you're applying for and what you can get out of it. Be strategic with what you do, because it saves you an immense amount of time, which will really only get more limited as you graduate. Do your research with your opportunities and ask yourself, what am I getting myself into, and can I commit to this opportunity? More often than not, I found that tackling less things but putting in more effort was often a lot more rewarding than trying to spread myself really thin and tackle lots of things half-heartedly. And finally, from me, it's not all about the points, which might seem kind of counterintuitive to this talk, but hopefully what it has shown you is that building that CV that's really strong, that may not necessarily count for points, is just as important, because you want to have that variety of experience and roles, and those are really valuable, and they help to make you a really well-rounded student as well as junior doctor. You'll find that having a strong CV helps you to get into programs, projects, and roles that are often a lot more competitive, and those can eventually lead on to scoring those portfolio points. So now I'm just going to let Radhika take the floor.
Thank you, Sarah. And so my two top tips is that, just so following on from Sarah, it's not all about the portfolio points, and you should be following your passions. So find projects that, you know, make you really excited, that you're really passionate about, and kind of fit in with your interests and your goals. Don't just do things just for the sake of it, because you're more likely to not put the effort in, and then you'll have a poor output of the project. So yeah, just follow what you're interested in. And then my final top tip is that medical school should always come first. When you're graduating, you want to be a good doctor, you want to be a competent doctor, you want to be a kind doctor, and all these things with research and medical education and leadership, they should always come second to you focusing on medical school and prioritising your mental health as well. So with that, we'd like to conclude the talk, and we hope that you found it useful. Just to reiterate, again, you don't need to do all these things. Don't feel pressured or daunted to start applying for things. We just wanted to give you an idea of the opportunities out there, and just like a couple things that you can pick and choose throughout medical school. So yeah, thank you for attending our talk, and if you have any questions, please feel free to post on the Slack, or at the end of the day, we'll have a Q&A. So thank you.
All right, bye, and good luck with your medical school careers.
Thank you so much, Sarah and Radhika. Sarah and Radhika did this for their virtual elective as part of their project, and they did an amazing job on teaching you about leadership education and just how to get involved in that. And I really enjoyed hosting that particular panel that they did and that particular project they did. So I definitely recommend watching Sarah and Radhika's teach. And also, I definitely recommend getting involved in virtual elective when applications open. So thank you guys so much for listening. Thank you to Hannah, thank you to Sarah, thank you to Radhika. You all did awesomely, and I think everyone learned quite a bit about cranial nerves, quite about leadership education and how to get involved, and just like so many topics that definitely need to be known. So thank you guys so much, and thank you all for listening, and have a great weekend.
Glomerulopathy or glomerular dysfunction can present clinically with nephrotic syndrome, which includes proteinuria, hyperalbuminemia, and edema, or it could present as nephritic syndrome with proteinuria, hematuria, hypertension, and a risk of an acute kidney injury. The diseases that cause glomerulopathies can present as a purely nephrotic picture, as a purely nephritic picture, or some diseases can present with a mixed picture and include features of both presentations. Purely nephrotic diseases include minimal change disease and membranous glomerulonephritis, both of which start with the letter M. And some purely nephritic diseases include the ANCA-positive diseases, antiglomerular basement membrane disease, IgA nephropathy, and another one is post-streptococcal glomerulonephritis, which will bring back an ASOT positive test or anti-streptolysin O test. So all of them have the letter A involved. Diseases that cause the mixed picture include focal segmental glomerulonephritis, nodular nephropathies, which include amyloidosis and diabetes, and membranoproliferative glomerulonephritis, which classically is right in the centre of both syndromes and includes all features of both syndromes. And finally, don't forget lupus, which can present as any type of glomerulopathy, so as a purely nephrotic, purely nephritic, or as a mixed picture as well. So that concludes a quick presentation on glomerulopathies.
Leadership is effective.
Strong leadership inspires people to work independently, but it takes real skill in leadership to bring people together for real change.
I think one of the most important things I hope to achieve is to get to know other colleagues and how they're meeting their challenges and kind of the ways that they look for solutions to problems, especially in leadership.
I'm really hoping to learn from the faculty and also my peers and see how I can develop as a leader.
So it's actually inspired me to really think deeply about who I am, not just as a leader, but as a person.
Just by connecting me with some really interesting people who have already had some great achievements and who I think will go on to have even greater achievements.
The HLA has empowered me to consider leadership in all its shapes and sizes and to recognise that I am also a leader.
I like to be pushed a little bit out of my comfort zone, so I think when you start to feel uncomfortable with things, that's a good stimulus for growth. If you're not feeling uncomfortable, then I think you start to stagnate, and I think that's what the HLA offers as an opportunity to do.
To think about my own leadership style, and also to try and put on paper some initiatives I'd like to lead in the future.
I can develop as a leader of the team that I'm already involved in with Medics.Academy, but also pick up extra skills that will make me more effective in leading medical clinical teams in the future.